All right, welcome everybody. My name's Lindsay. I am a 13-year thyroid cancer survivor from Albany, New York, and I have hypoparathyroidism. It's nice to be in the room with some fellow orange banners here. I'm very pleased to introduce our two speakers. Dr. Sarah Oltmann is an endocrine surgeon at the University of Texas Southwestern Medical Center in Dallas, Texas. She is the section chief of endocrine surgery at the University of Texas Southwestern Medical Center and director of endocrine surgery for Parkland Health and Hospital Systems. She attended Baylor University, graduating cum laude, and she went on to earn her MD at Texas Tech University Health Sciences Center, graduating Alpha Omega Alpha. She completed her general surgery residency at the University of Texas Southwestern Medical Center. During her surgery training, she was diagnosed with thyroid cancer, which greatly influenced her decision to pursue endocrine surgery as a career. She completed an endocrine surgery fellowship training at University of Wisconsin. Her research interests include management and clinical outcomes in endocrine surgery, and she is a 2015 recipient of the ThyCa research grant for her work on cancer progression and therapeutic response in a mouse model of medullary thyroid cancer. We're going to hear from Dr. Oltmann first, and then we'll be joined by Dr. Gaba, an associate professor of medicine and program director of the Endocrinology Fellowship at Bayer College of Medicine in Houston, Texas. She specializes in thyroid and parathyroid disorders with particular expertise in thyroid cancer, especially advanced and complicated cases. As medical director of the Thyroid and Parathyroid Center at the Dan Duncan Cancer Center, she leads a multidisciplinary team to provide comprehensive patient-centered care and contributes nationally to guideline development and educational initiatives in endocrinology. So thank you both for being here.
Thank you very much. So I will take the first portion of our talk today, just discussing, first off, what are our parathyroids and why are they at risk during thyroid surgery? And why do we manage hypoparathyroidism immediately after surgery a little bit differently than when we do after it appears that the parathyroids are not going to recover? So those are going to be our goals today, and then specifically what the goals are of our treatment those first few weeks to months after surgery. And that goal is to essentially try to get those parathyroids to recover. So the parathyroids are these little glands that live in our neck. Their job is to feel the calcium in our blood. And when the calcium starts to get low, they turn on and make a hormone, and that hormone helps bring the calcium level up. Once the calcium gets high enough, the parathyroid is supposed to turn off. And so I think of it like being on a teeter-totter. You always want to check the two things together. So as you can see on one side, we have calcium down, PTH is up. That's a normal teeter-totter. We have calcium up, PTH should be down. That is also a normal teeter-totter. So that's how the parathyroid and the calcium ends up being related. And the parathyroid hormone has a lot of different jobs in our body. So it causes calcium to be released from the bones. It slows down the building of new bone, and it actually kind of triggers the bones to break down a bit. And that's how the calcium gets released. With the kidneys, the hormone increases the calcium being absorbed out of the urine. Actually, technically, it's reabsorbed. It gets dumped in, and then we try to pull it back out. It blocks our phosphate from coming back out of the urine. And the hormone also helps us activate vitamin D. And vitamin D is one of the helpers with our calcium. In the intestine, the parathyroid hormone has a little bit more of an indirect effect. But by activating the vitamin D then helps us absorb calcium and phosphate from the food that we eat. So where do the parathyroids live and why are they at risk during surgery? Now, most of the time, and I'm going to probably walk over here because they've got a little bit of a video at least. Typically, we hear about them being just right behind the thyroid, usually one towards the top and one towards the bottom. But not everybody reads the textbook when they were born. And so they can be in a lot of different places. Oftentimes, we may see them anywhere down here in the space where a lot of the lymph nodes, so especially for patients who've had central neck dissection, they're usually a lot more higher risk for having those parathyroids removed with those lymph nodes. Not shown here, but sometimes you can have parathyroid glands actually inside your thyroid, where we can't really tell that that's where they are. The pathologist finds them on the microscope after the fact. And additionally, especially with people who have had really bulky disease, we will see parathyroids down in the thymic tissue. That's some fatty tissue with lymph nodes that are in the upper part of our chest. And some patients with really bad nodal disease in the middle of their neck during surgery, we pull all of that tissue up because we want to get all those lymph nodes out and make sure we're not leaving any cancer behind. So typically, as a thyroid cancer surgeon, I am really diligent to try to protect the upper parathyroids because they tend to be in a little bit more protected location. Usually there's not a lot of lymph nodes up there, but these lower ones are just right in the danger area where we're going to end up kind of taking them out. Now, anything we take out in the operating room, we do our best to look at with our eyeballs and see, can we tell what's parathyroid and what's not? Sometimes it's not clear, and we might take a little biopsy and send it to our pathology friends. The sad thing is, with the quick look underneath the microscope, sometimes thyroid tissue and parathyroid tissue looks a lot alike. And so I've had, even on frozen section, be told one thing, and then later on, when they've got the time and the ability to do more formal slides, it's actually something else, not the parathyroid. So what happens after thyroid surgery? Well, during the surgery, one or more of your parathyroid glands may have had their blood supply affected in a negative way. The blood supply to the parathyroids is really tied up in the blood supply to the thyroid. One or more glands may have been inadvertently removed. One may have been inside the thyroid. One may have been in the middle of all of those big old bulky lymph nodes that needed to come out. The thyroid surgeon may have seen that. They may have tried to auto-transplant one of your parathyroids, and all that is mincing it up and sticking it sometimes in muscle in your neck or in a little bit of the soft tissue in your upper chest. But at the end of the day, do you have enough parathyroid tissue to respond to the low calcium? And that's what we worry about when people are starting to struggle. And so if there's not enough parathyroid tissue, you can't make enough hormone, and your body has a trouble managing your normal calcium level. So our teeter-totter, it's broke. Calcium's down, PTH is down. That's not the normal relationship. We have a problem. So right after surgery, some surgeons have different strategies depending on what they did or saw. Some will just automatically put everybody on calcium. I personally start with the hormone levels and try to see where are we starting. Depending on the timing of it, it might be right in the recovery room. It may be a few hours later. It might be the next morning. That part isn't really that significant. It's just more so, are they looking? And then based on what the hormone is, are they also monitoring your calciums and starting you on supplementation? So if the hormone level is low, usually we're going to start you on some calcium and see its response. Sometimes we might just start by seeing how it's making you feel. Sometimes we're going to check blood work. And then, as I mentioned, vitamin D is a helper in all of this. So we may also start you on a form of vitamin D supplementation called calcitriol. And in the short term, our goals are just to keep the hypocalcemic symptoms at bay. That's the numbness, that's the tingling, that's the cramping. And if as the calcium drops really low, that's also some of the anxiety and the altered mental state, or just that feeling of dread that comes over you as the calcium drops really low. We don't want to bump the calcium up though so high, because that lower calcium is what's going to be triggering the parathyroids, reminding them they need to come back to work. So our goals of treatment are not to bump your calcium into the middle or upper end of normal, because, well, if it's up on one side, the parathyroid's like, oh, I don't need to do anything. You got it covered. I'm good. And so while your body is trying to heal from surgery, they're not really given any motivation to try to come back. And so in the short term, this is really what we're focusing on. Now, there's a couple of different forms of calcium that we'll tend to use. And there's some different pros and cons of each of these calcium forms. Really, it's just two main ones, though. And if you go to the drugstore, you'll see there's about 8 million various different forms. And you really want to make sure what is coupled with the calcium. So I'm going to talk about the two that I generally will use, and you really want to stay away from the other ones. So calcium carbonate, this is also Tums that we use for heartburn. It's cheap. They're chewable, so right after surgery, it's really easy to swallow. Your sore throat, it's okay to go down. It gets absorbed because of what's paired with the calcium. It gets absorbed in the stomach and in the first part of the intestine. It gets into your blood system really fast. You've already done half the work. You've chewed it up in your mouth, so when it hits your stomach, it's going to start getting in. So within 15 minutes, you might start to feel the calcium hitting your bloodstream. but it does need an acid environment. And so the doctors need to be really mindful of that, because if you've had a gastric bypass, what goes in your mouth is never going to get into the space where this is going to get into your body. And if someone's got a problem with really bad ulcer disease or reflux where they're on a type of medication called proton pump inhibitors, that turns off your acid environment. So this form of calcium is not going to be very good for you because you're just not going to optimally absorb it. The other form of calcium that we'll primarily use is calcium citrate. These tend to be much larger pills. I refer to them as horse pills. Even the small ones are still very big. You can crush them or break them up, but they aren't really chewable in the same way that Tums are. They do tend to be a little bit more expensive. I worked at a county hospital for the large part, so I try to be very mindful if most people were only needing calcium for a short period of time. Tums will still get used up. Everyone gets heartburn. Everyone gets upset stomach. So usually start with that. But if we're needing something more long-term, I think this form of calcium ends up being a better solution. It takes longer to get in. It's got to go further down into your intestine before it starts getting absorbed into your body. And for that reason, it takes a longer time before you're going to start feeling it in your blood system. So if you're having an acute bout of symptoms, this form is going to take some time before you're going to feel better, compared to the Tums, where usually with the Tums, within 10, 15, maybe 20 minutes, you should notice a difference. The Citracal doesn't need acids, so it's great for patients who've had who need to stay on their acid reflux medications. And for patients who've had gastric bypass, what goes in their mouth after gastric bypass, this form of calcium is going to get to a place where it can be absorbed. So those are other things too. And I know sometimes people are very hesitant to speak up about bariatric surgery, but this is one of the reasons why it's so critically important to include that when your doctor asks you about previous surgeries, because it does affect how your body responds to different medications. There are some side effects from being on high dose calcium. So you can cause abdominal bloating, nausea, constipation. That tends to be a little bit more with the Tums, not so much with calcium citrate. It also can cause some mental fogginess and confusion if you're overdosing it and it's causing your calcium to go too high. And again, if we checked your blood work, we want to make sure we're not putting that calcium level in the mid to high end of normal, or heaven forbid, too high, because that's going to turn those parathyroids off and really not motivate them to heal. Now with vitamin D, it helps with our calcium regulation. It's not unusual for people to be a little bit deficient, but parathyroid hormone is needed for us to convert or activate vitamin D from its storage form into its active form. And the active form is this 125 dihydroxy. If you don't have PTH, you can't activate the vitamin D yourself. And so instead, you really need to take a form of it that will compensate for that. And that's what this calcitriol or Rocaltrol are. They're usually little gel caps, and you're dosing maybe twice a day, once a day, and kind of titrated. This medication also gets used with a lot of our patients on dialysis because those patients struggle with low calcium for other reasons. If you're on too much of this form of vitamin D really early on, this also does feed back, and it has a couple of different ways that it will suppress your parathyroids. So it acts directly on the parathyroids because it's sort of an end result of what the parathyroids have been doing. If you've got too much of this floating around, the parathyroids are like, oh, well, I'm really killing it. I don't need to work so hard. I can go back on vacation, and they're not going to recover when the body's trying to heal. So early on, we really want to try to minimize how much we rely on this to keep your calcium levels up. Also, if you're on too much of it, it's going to really bump your calcium levels up, keeping them too high, and that's going to end up suppressing those parathyroid cells because, again, they say there's enough calcium around, they don't need to work. How long is the healing process? So when we consult patients before surgery, we do mention the temporary form of this. I'll usually quote patients somewhere between 10 to 15%. Anywhere from a few weeks to a few months after surgery, they may need to be on calcium a few times a day. The glands typically will recover function within, usually the first 2 weeks to a month and a half. And the point during that is the doctor should be working with you to try to actively start weaning how much you're on. Again, with the goal of just keeping your calcium just on the low end of normal and really trying to minimize what symptoms you have. It's the same time frame as the healing of the rest of your neck. That's when everything in your body is geared towards healing and getting better and recovering. And once that's done, there's nothing else around to try to help motivate the parathyroids to get back and growing. But they're not all we're going to recover. And that's when we need to transition to a more permanent strategy, more permanent solution. And long term, I'm going to let Dr. Gaba kind of talk about that portion of it. It's sort of, up front. Why does it happen? Why do we manage it differently right after surgery? And then when we convert and we're like, okay, it doesn't look like this is going to bounce back, we change our strategy. It's not that the strategy was wrong from the get-go. It's that the situation was different and our goals were different because we were trying to convert as many people as possible back into a recovered state. But I will turn it over to Dr. Gaba, so she'll take over sort of the more long-term management, what are the consequences and whatnot.
Thank you. And while we get our PowerPoint pulled up, I wanted to say that I'm really honored to be with all of you today and hope. All right. So really building off Dr. Oltmann's presentation today, my task is to focus on sort of long-term consequences and management of this disease. So when do we say that it's long-term or it's chronic or it's something that we really have to be worried about to be a lifelong disease process that we will be dealing with is when this low calcium, which is due to this inappropriately low parathyroid hormone, when it lasts more than a year. So more than 12 months, then we are most likely looking for the disease to be permanent. And depending on what has caused it to begin with, it's very rare, but sometimes these parathyroid glands can wake up again. But for the most part, we consider it to be permanent once it's chronic, okay? It's a rare disease, but it affects thousands of people in the world, especially women. If you see, the global prevalence is around 6.4 to 37 per 100,000 patients. And the incidence is slightly different, right? It's 0.8, which is a study from Denmark, versus a 2.3 per 100,000 people, which is from a study in India. But why does it look so different? It's because of how chronic disease has been defined, how the follow-up has been looked at. So it's very variable, and that's why these numbers look a little variable. Now, this disease does cause significant symptoms, comorbidities, so leads to a lot of healthcare usage in terms of like ER visits and hospital visits. So it is not only an emotional burden, but also a financial burden. And then what does it affect? It's really a multi-system disease. So it affects your kidneys, your bones, your eyes, your heart, let it be any system, okay? So it's not just low calcium causing the couple of symptoms that we think we usually will encounter because those are common symptoms. It's really a multi-system disease. And these symptoms, like I said, can be a lot spectrum. It can be very mild and it can go up to being very debilitating. Now, what is causing these symptoms? So yes, a low parathyroid hormone will cause low calcium levels. So most symptoms are coming from just that low calcium in the blood. But also remember that different people feel that threshold of where the calcium is at and what kind of symptoms they're going to be experiencing. So it's very variable. So your calcium as such on your blood work could look great, but still you could be having symptoms. And that is totally, absolutely normal and happens. So please bring that up with your physician despite seeing a normal calcium on the blood work. Because like I said, different people feel it differently. And then just how the description of these symptoms, it can be very different for somebody else who's sitting at, say, a calcium of 8 versus another of your friend who had a calcium of 8.5. The patient could be feeling different symptoms. And I can't stress that enough, okay? But what kind of common symptoms? And Dr. Oltmann alluded to them a little bit. So calcium is responsible for a lot of nerve and muscle conduction in the body. So when the calcium is low, you can have this sort of neuromuscular irritability is how we call it, but you will feel it, or the patient will feel it as tingling in the fingers and in the toes. Also around their mouth, which we call like perioral numbness. At the tip of your tongue, it could be fasciculations or little like contractions that could be felt. Also, patients can have muscle cramps, which can be like spasms or even feel weak, especially more with like physical activity. So exercise and other things can also enhance these symptoms. Now, laryngospasm, which is pretty much larynx is the voice box, so it can cause like contraction. So spasm means contraction of the voice box, which can block the air that goes down to the lungs. So it can cause shortness of breath. Now, that can also happen, or asthma, but these are very rare, but can totally happen. In people who have a history of some kind of seizure disorder, or younger patients, you can also have an increased propensity to develop seizures when the calcium's low. Now, tetany is what we call these muscular spasms. So that's called as tetany. And I thought these are some very nice or cool physical findings, which even the patients themselves can elicit. So I wanted to kind of point these out. The first one is called the Trousseau's sign, where, when you're at your hospital visit, at your outpatient visit with your doctor, you're getting the blood pressure checked. So when the cuff on the arm tightens up, the nerve gets pinched. And remember, calcium is important for that nerve conduction. So when that nerve is pinched, literally this kind of a position here, where you feel like you're walking over the table. So your thumb and the fingers contract in a certain way, and that pretty much tells us that the calcium's low. And when we see something like this, we are really worried. Usually calcium's really low when you're pulling up the Trousseau's sign. Now, the other one is called the Chvostek sign. How this one works is we're tapping literally at the cheekbone right here. And so there's the facial nerve, which if the calcium's low, it'll contract. And so your face will be pulled on that side. So it's like a facial twitching that can happen. And the degree of response, like if it's a big twitch, like a big contraction, then most likely the calcium's really low. So this is something you could even check at home. But realize that 15% of normal patients can also have that. So it's not a sure shot sign of low calcium, but if you've not had it before and you've developed it after surgery, this is something your doctor might do as a physical exam when you're in clinic. All right, so we said neuromuscular irritability, but also lots of different symptoms with brain fog. As the longer duration of the disease, you can start to feel kind of this mental lethargy, where you're not able to concentrate, there's memory changes, you can't focus correctly. And of course, all of this leads to a lot of anxiety. So increased anxiety, and a lot of studies have shown that these patients have increased anxiety scores on the different scoring systems. There's a hypoparathyroid like clinical symptom score, where they'll score higher on their anxiety parameters. And imagine all of this like emotional burden of the disease can lead to a reduced quality of life. So not emotional, but also physical, when you're actually having those cramps while you're trying to do something, trying to live your daily life. And so really, really a huge reduction in quality of life. These patients can experience that. Now, these are commonly known, right? The cramping, we said the tingling and the numbness. Most patients are aware of these symptoms. They know to watch out for those, because that's when you take that extra calcium, when these symptoms come on. But there are a lot of other symptoms that a lot of people are not aware of. So one of them, so the parathyroid hormone, very important for your kidneys, right? So if the parathyroid hormone is going to be low and we're replacing it with calcium, they all kind of link together in metabolism. And so there's a higher risk for developing like renal insufficiency, or your kidneys don't function like they're supposed to. And the prevalence can be anywhere between 2 to 40%. For the most part, 15 to 20% patients might develop this. So at a 3 to 4 higher risk of developing kidney disease. And what happens is either you can develop what we call nephrolithiasis, as kidney stones, versus nephrocalcinosis, where this is a nice picture right there. So you see all these dark, so calcium will appear white on most of the imaging. So all of this is just calcium deposition in the kidneys. And that is what nephrocalcinosis is called. So that can happen too, okay? Now, in terms of the heart, how does it affect the heart? There's definitely an increased risk of cardiovascular disease. And you can go into something called an arrhythmia, where the rhythm of the heart is like, it's altered, right? And so how your doctor might want to check that in clinic is they might order an EKG. So there's like a classic finding, which in our world we call like there's little intervals that we look when we look at the ECG and how we read it. We've given them pretty much terms. So there's something called a QT interval, which gets prolonged. But not to get into too much of nitty-gritties of that, there'll be EKG changes. Your heart can go into an irregular rhythm. So you have to be careful about these things. Congestive heart failure and other more severe heart diseases are rare, but can happen as the duration of the disease, as longer the duration, more the complication that we could be looking at. Now, in terms of bones, what happens is how our bones and calcium, like Dr. Oltmann said, the calcium is released from the bones. For that, it has to remodel and the turnover has to be there. So when your parathyroid hormone is missing or it's low, this bone turnover is reduced. So as such, the bone mineral density, which is like you know how we do DEXA scans or bone imaging scans? So the bone mineral density might look improved, but we don't know how strong that bone is really because it hasn't remodeled, it hasn't turned over. So that's what kind of this figure shows here. There's very little remodeling here. And so usually when the remodeling is reduced, there's an increased risk of fractures because the bone is not strong as much as we'd want it to be. But really in this disease, we don't really know if it transforms kind of into increased risk of fractures, and that's because we have a lot of like small studies. We don't have big trials to kind of support that. But just thinking intuitively about it, the bones are not strong. So definitely that microarchitecture of the bone is altered. So something to keep in mind. Now, this one is most patients that do not know about this, but the chronic hypoparathyroidism, or the longer you have low calcium, you're predisposed to cataracts. And so 2 to 4-fold higher risk. And really, if you treat the calcium, it does arrest the progression, but sometimes people will need surgery before like 35 years of age. So usually we'll see with older age, we'll see more cataracts, but in these patients, it could present earlier. And the mechanism is not very well understood, but electrolyte or calcium changes in the fluid that surrounds the eye sometimes can play a role. Now, there's something called basal ganglia calcifications. Now, what does that mean? It's not one of the more common complications. Many of you might not have heard about it. So incidentally, if you were to have some imaging of your brain for some reason, then sometimes they will pick up these calcium depositions. Okay, sorry, I'm trying to find my cursor here. So right there. So when you find these kind of calcifications in places they're not supposed to be present, we call them like ectopic or ectopic calcifications. Ectopic meaning in areas or places the calcification or calcium deposition is not supposed to be in. So these are usually picked up incidentally. Now, what are the consequences of these? Not very clear if they have a real consequence, but there are some studies which show, if you've heard of the disease called Parkinson's disease, where you have tremors and other things, so maybe association with that. But usually, like I said, discovered incidentally. And then last but not the least, infections. So definitely patients of chronic hypopara, long-term low calcium, they're at an increased risk for all kinds of infections, and especially urinary tract and respiratory tract infections. And we're talking about surgical hypoparathyroidism, but it can also happen in other causes of hypoparathyroidism. Again, mechanisms unclear, but calcium definitely playing some role in the immune system in the body. But before we finish up like clinical manifestations, there's also something called like ectodermal manifestations. What does that mean? Basically, your nails, your hair, your skin will start to become very brittle, very puffy. So those changes can happen over time as well. All right. So with finishing up kind of how the disease would manifest long-term, let's talk about how are we going to treat it. So even before we go to treatment, let's think, what are we trying to achieve? Like, what are our goals? So yes, we're trying to avoid that low calcium, right? That causes all these different symptoms. And so what calcium range are we kind of looking at? And Dr. Oltmann alluded to it, that you want to be on the low normal range of whatever lab you get tested at. So you want to be somewhere between 8 to 8.5 milligrams per deciliter. Now, in acute, which means like in the short term, it's helpful to help wake up your parathyroids, right? You don't want that calcium to be on the higher end of the normal range, because how are the parathyroids going to try to wake up? But long term, now we know they're not waking up, so we know we are going to be on treatment for a long time. So why don't we want to keep them on the high normal ranges? Because I will show in a figure very soon that all that calcium that we take by mouths is taken out of our body through the kidneys. So the more the calcium that we take, the more is going to come out of the urine, and all that calcium can get deposited in the kidney and cause those kidney complications we spoke about. And we'll talk a little bit more in detail about it very soon. But we're trying to keep our calcium in between the 8 to 8.5 milligram per deciliter range. And then remember, when the calcium's low, it also causes the phosphorus to be high. So the parathyroid hormone is playing this whole calcium and phosphorus, kind of maintaining those levels in the blood. So when calcium's low, the phos can be high. And one, normalize that phosphorus too, because it's an important electrolyte, serves its own set of functions. And then Remember, I said more the calcium, the more you're going to be omitting out in the urine through the kidneys. So we want to keep that 24-hour urine calcium less than 300 is our target, because that can cause complications with the kidney stones and the deposition of that calcium in the kidneys. And so there's something called a calcium phosphate product, where literally your calcium, you multiply it with the amount of phosphorus in the blood, and you want that number to be looking less than 55. Because higher your calcium phosphate multiplication product, the more complications you're going to be looking at, okay? And then what other kind of goals are, of course, your quality of life. You don't want to develop complications. You don't want kidney stones. So all of those fall under our kind of goals for treatment. Now, in terms of management, how do we decide what's the best way to do? So I wanted to kind of give you a little bit of background, which as patients you might not realize that, when we come up with these management guidelines, they're driven by case reports, they're driven by consensus statements, standards of care, etc. So there's European Society of Endocrinology, which gives its own kind of guidelines. And then ACE is the American College of Clinical Endocrinology. So they come up with their kind of clinical review on how to manage this disease. And there's something called the International Conference on the Management of Hypoparathyroidism, where the second time that they met was in 2022, which was around the pandemic. But pretty much this is an international task force that got together, had maybe like 50, 60 international experts. And they took more than like 18 months, almost 2 years, to come up with guidelines that were endorsed by 60 professional societies. So a huge deal. And it was a big breakthrough in how hypoparathyroidism is managed. So for the most part, most people, most like societies or national guidelines will kind of echo what this international conference has come up with. Now, this was 2022. Since then, we've had like a couple more reviews that are out. So keeping all of those in mind, we'll discuss like how to best manage this disease. Now, most hormone deficiencies, in medicine, what we do is if the hormone is deficient, we're like, okay, we are going to replace that. Like, for example, if your thyroid hormone is low, then your doctor might put you on thyroid medicine, which is levothyroxine. But in this case, it's not as easy because there's not a pill that you can take right away to replace that parathyroid hormone. And so we follow first. So it's not first line to be on parathyroid hormone replacement. So then what do we do is the conventional treatment, which is the calcium and the vitamin D, what Dr. Oltmann had spoken about. So what we do acutely on short term, we also do long term. And so she went over this in detail, but just to kind of recap, conventional management, calcium is going to be the oral calcium that we take by mouth, which is over the counter. Now, she spoke about the two different forms and very nicely told you which will work in what case. But as a patient, what I want you to pay attention is when you look at your bottle of calcium at home, you want to look at the back of the bottle to see how much elemental calcium it has. That's what your doctors care really about, okay? And so carbonate will have almost like 40%, and that's why fewer pills. Whereas citrate only has 21%. So that's why the larger, the bigger pill, because just that one pill will offer you less calcium compared to a carbonate pill. And then, of course, preferences based off, the acidity, if you're on certain medications, etc. But why don't we now want to do something else like calcium gluconate or lactate? Because those have even less than 20% of calcium in it. So can you imagine how many pills you'd have to take to maintain that calcium? Now, in terms of how to make these choices, I think Dr. Oltmann discussed this already. So the ones that I want to highlight are probably that you want to spread your doses through the day for best absorption. Don't try to take it that in the morning, I'm going to take my 6 pills together. So spreading it out definitely helps. And then before any strenuous physical activity or exercise, remember to take some extra calcium because exercise aggravates all that muscle cramps and other things. So I literally had a patient yesterday. We came up with a plan of when she's a horse rider, so she's going to a contest very soon. And so I told her 2 extra pills right before your activity. And then remember, don't overdo it. Sometimes when that tingling and that uncomfortable feeling comes on, we want to take as much calcium as quickly as possible. But that extra calcium can build up. It has to go somewhere. So it can get deposited in your arteries, in your kidneys, in your heart. So you have to be careful about that too. And then avoid to take it with some other medications which can interfere in the absorption, like iron supplements or multivitamins. So you want to kind of club them up separately. Okay. So we spoke about calcium. The other important conventional management is the vitamin D. And like Dr. Oltmann said, we want to do the activated vitamin D because that helps in the absorption of that calcium. So it's the calcitriol which is a short half-life. So usually if it's a small dose, once a day is okay. It stays in your body for a couple hours as its half-life. But if your dose is, so if you're needing more than like 0.75 micrograms per day, you want to divvy it up. You want to take it twice a day or thrice a day. That might work out better. Now, calcitriol is more used in United States, but we have alpha calcidiol, which is in Europe. It's the same activated vitamin D, but a little different. It's half as potent, but much more used in the European countries. So that's your activated vitamin D. Now, you do not want to forget about your parent vitamin D, which is your regular vitamin D. So when you go over the counter and try to find just regular vitamin D to be taken, you can see two different forms, okay? So there's D2, which is more plant-based. It's called ergocalciferol. And then you have D3, which is animal-based, and it's called cholecalciferol. But you'll see all of these different supplements on there, and usually it'll be 800 to 2,000 international units per day. So you want to take your activated vitamin D, but also the patients need to be on parent vitamin D or just regular vitamin D. Very important to remember about an electrolyte called magnesium, because what happens is when the parathyroid hormone level is low, the magnesium in the kidneys is not absorbed like it's supposed to. So it causes low magnesium. And then magnesium is high or low, very important for the kind of the parathyroid hormone to function. So they kind of have an interesting relationship. So if the magnesium is low, you can correct that and it'll help the calcium and everything to be much better absorbed. And then sometimes, despite doing all of this, you're on the right doses of calcium, right doses of vitamin D, your magnesium looks great, but sometimes the phosphorus is just high, and that's the disease pathology. Remember, the calcium will be low, the phos will be high. So we sometimes need to specifically target phosphorus. And in those cases, a low phosphate diet helps, but there are certain medications which are called phosphate binders, which help because they bind that extra phosphate in the bowel. And so kind of coming back to calcium carbonate, which you take with food, you can take it with meals. When you do that, it actually helps because it's also binding that phosphate, which is released in your bowel from food. So calcium carbonate helps in that regards too. So you have to think about the phosphate is what I'm trying to say. All right. Now, this is all conventional management. And I wanted to point out that remember we said that calcium, as soon as it hits that 8 in the blood, the 8 milligrams per deciliter, it'll start to come in your urine. So that's the cutoff right there. So when it hits 8, you see how dramatically the urine calcium goes up. So when the urine and the calcium goes up, now we are at risk for all those different complications due to the extra calcium in the kidneys. And so what can help with that? So once your doctor checks the 24-hour urine calcium and it's high, there are some ways to combat that. So there's a class of medication which are called thiazide diuretics, which basically would help in the kidney to reabsorb that extra calcium that's trying to get out. And so that is very helpful, and a low salt diet will help manage that urine calcium. But again, it's all kind of interfering with different electrolytes. So different electrolytes need to be watched out for when you're on these medications. Now, conventional management is great, right? We know we have activated vitamin D, we have normal vitamin D, we have phosphate binders. There's so much out there, but it's not enough. And the patients who struggle through this disease know that. Just with these, it's still hard to maintain your kind of calcium levels. And again, with diet, with kind of activity, your requirements are different. How do I know if I need 2 extra pills today, or I'm going to be walking an hour? Do I need 3 extra pills today? So there's a lot of burden with that to decide how much to take and when to take. And then sometimes the symptoms will persist. Your calcium's looking great. It's 8.5 on blood work, but oh my goodness, I still have the tingling. I still have the cramps. And so the quality of life starts to get affected. And then, like Dr. Oltmann said, sudden calcium supplements can cause all that nausea and bloating and constipation. So those are side effects, and real side effects that patients live with. So all these medications also come with their own side effects. And then remember, the calcium urine is going up. Oh, now we have to be on another medication, the thiazide diuretics, like we said. So it's a lot of things to kind of keep in mind. And then bigger, large pills, frequent pills. And really, we don't know how much they're helping. We said, great, they're helping with maintaining that calcium, but maybe the kidneys have to be protected, and then we don't really know what it's doing to our bones. So a lot of like ifs and buts. So we've been doing this for years, but we don't know if it's the best way to do it. And so that leads us to think about, should we actually give the patients parathyroid hormone? How would that work out? So when do we want to consider that? It's not a routine replacement, right? Because it's not something oral by mouth that we can give to the patients. So there are 3 different kinds that we'll talk about today. Now, the parathyroid hormone To kind of understand those three, we need to understand the parathyroid hormone. So it is called a peptide hormone, which means pretty much it is made up of amino acids, which are one of your, like the different cells are made up of different constituents, and amino acids are one of those, okay? So this hormone is an amino acid which goes from 1 to 84, okay? And the first 34 is the active form of the hormone, but the full length is really 84. And so when we replace this parathyroid hormone, it has to be injected subcutaneously into the body because it's going to be destroyed in the liver otherwise. So we can't give it by mouth. So let's talk about the first one. Oh, even before that, when to consider these. Again, when you're not able to tolerate. The things we spoke about as limitations or challenges with the conventional management, those are all really related to when to consider this. All right, so the first one is, remember, the smaller portion, the 1 to 34 amino acid group. And so that's biologically active, we said. And actually, FDA approved that in 2002 for use for osteoporosis. But really, for hypoparathyroidism or low calcium, it has been used off-label. And how it works is, for osteoporosis, it's a 20 microgram dose that's done once a day. But you know, it has a short half-life. So to maintain calcium levels, we don't know if once a day is going to be enough. So what studies did was clinical investigation started with twice a day dosing. And they found that it really, really helped cut back the calcium and vitamin D in almost 50% of the patients. So it did help. And so if at all it is given off-label, we usually will do twice a day dosing. So once a day dosing won't cut it out, okay? And in fact, a lot of different centers have tried this as a continuous pump. Because imagine, this is not just the bone turnover or osteoporosis that we're trying to control. We want those calcium levels in blood to be maintained throughout the day. And so in these patients, sometimes continuous infusion pumps that provide this medicine help maintain that calcium even better. But it's not the best way of doing things because, you know, it can lead to that activated vitamin D to be high and even more calcium in the urine to be excreted out. But when we didn't have anything else, this worked great. So it was used off-label, okay? Now the 184, remember, it's the full molecule. It goes up to all the 84 amino acids. So it's a full length. And in fact, this got approved in 2015 for treatment of chronic hypoparathyroidism. And so it had longer half-life, so it didn't have to be double dosed or triple dosed during the day. So it could be given once a day, which was great because it's an injection. Remember, you're actually injecting it. And so it was well tolerated. Everything was looking great. You could cut back on your calcium, vitamin D. So it really helped. And if you all remember, it was marketed as Natpara around that time. But in 2019, unfortunately, it had to be withdrawn from the market because of some rubber particles that were found in the formulation for the injections. It was found to have some rubber particles. So we no longer have access to Natpara anymore. But just to kind of give you background on why did this get approved, it was based off the REPLACE trial. Now, not to get into too much nitty-gritties of the study, but when it says blinded, it means, and placebo control means there's a patient arm and there's a control arm, which means normal patients versus patients who have hypoparathyroidism. So that's placebo control. So one will get the drug and the other one will get nothing. We call it placebo when it's just like a sugar capsule, okay, for example. And blinded means they don't know. The patients don't know who's actually getting the drug or who's actually getting the sugar pill. And so they looked at 134 patients, and out of these, you know, more than half actually met the kind of endpoint that the study was looking at. And that was a 50% reduction in all the calcium and the vitamin D that they were getting. And then the urine calcium went down too. And other studies kind of confirmed. So it was a great drug that was released, but so sad that it had to be pulled off the market. And so now what we have, the latest on the market, is something called the TransCon PTH, okay, which is the palopecteriparatide. What they did was they took the 134, remember that active part, and then they linked it to something called polyethylene glycol. So what that does is it just releases the same active parathyroid hormone, but over a longer time. So we call it like sustained release. So over long term, it'll keep releasing that little bit of parathyroid hormone in the body. And so really temporarily, it will restore the levels of the calcium that are needed in the body, the parathyroid hormone levels in the body. So it improves not only short term, but long term, your symptoms and different complications as well. So this was approved last year. And it's a long half-life because it's slowly getting released over the day. And so it can be a single injection. It's long-acting. And then as soon as you start it, you can start to kind of cut back on the calcium and the vitamin D. So just to show you quickly that this one was approved based on the pathway trial. So what was that? When we call it randomized placebo control, remember placebo control means the sugar pill, and randomized, and I'll tell you in a second, it was 2:1 randomization. Now, what does that mean? That means that for every 2 patients who got the drug, 1 did not get it. And they didn't know who was getting it or who was not getting it, okay? So they took 84 patients who were on calcium vitamin D, and then they randomized them to get this new drug, the TransCon PTH. And so here are kind of the endpoints. So endpoints were calcium should be normalized. You should be able to get off the calcitriol. You should be able to get off the calcium. And then, whatever drug of the TransCon it is, you kind of maintain it. And if you were to see, almost 80% patients met all these 4 criteria. And almost 90% of patients were able to come off the conventional therapy. So it worked. It worked great, okay? And in fact, it's marketed now as your VPAth. And within a week of getting on this medicine, you can start to cut back on your calcium and vitamin E. And I just share this as like the titration table, which is accessible to everybody who's considering to be on this drug to see how soon or what changes will happen to the regimen, okay? All right. Now it's working great, but is it safe? Is it safe, and what is the tolerability of this drug? So generally, very well tolerated. The common side effects that were noted were some injection site reactions, some skin reactions. You can have hypercalcemia because sometimes it's overcorrecting itself too quickly. So sometimes hypercalcemia can happen and some headache. And I think there were 5 serious adverse events is something that needs like hospital admission or something that really catches attention. Out of the 5, 1 was related to treatment of the patients. Remember the 134 the 84 that were randomized. And so that was just related to the hypercalcemia. So their doses had to be adjusted, were not adjusted soon enough pretty much. So overall, well tolerated. But with that, these are kind of the new pharmacological medications out there, right? So the TransCon is the new kid on the block. I have maybe like 2 patients on it, and 2 are getting ready to be on it. So, experiencing it real time to see how patients feel on it. But also, apart from medications, we can do some kind of non-pharmacological things to help with this disease too, which is diet, right? Diet is a big part, we said. And so the calcium's low, so you want to eat food that are rich in calcium, right? So fortified soy, nut milks, etc. can help. And then you want vitamin D, so all fish, salmon, shrimp, fortified milk, so that's a good idea. So things that are rich in calcium, things that are rich in vitamin D are always a good idea. Now, you don't want high phosphorus foods because really we don't want that phosphorus to be high. So you want to avoid foods like chocolate, cheese, nut, etc. And then remember to avoid food rich in both calcium and phosphorus because the calcium phosphorus product, which remember the magic number was 55, we want to keep that low. So some foods like dairy products can be rich in both. Great for the bones as such, we tell our osteoporotic patients to be on it. But when you have chronic hypoparathyroidism, you have to be careful about them. And then low sodium diet always helps. So the lower the sodium, the less you're going to be excreting the calcium in the urine. And I also wanted to quickly touch base on some emerging therapies. So it's not like science has been trying to work on, a lot of investigators are trying to figure out if there's an oral way to take this hormone. So there's something called enoboparatide, which is again an injection. That is in a phase 3 trial. So phase 3 means, you're already comparing to like placebo, like normal patients. So that's when it's a phase 3 trial. And there's some drugs like encalcerate, which can be an IV. But really, I think this one is interesting, the 4th one on the slide, which is oral small molecules, which means you can literally take it orally by mouth. So all of this is still in progress. Lots of phase 2, phase 3 studies going on. And for follow-up for these patients with chronic hypoparathyroidism, so we have them on the right treatment, the calcium, the vitamin D, the parathyroid hormone replacement. But remember, how quickly you need those electrolytes or calcium, magnesium, everything checked depends on how you're doing. If you're doing great, then you can space it out. And usually you like to check every 3 to 12 months. Now also do not forget ever about the vitamin D. So actual vitamin D levels, which is the 25 hydroxy vitamin D, and then the 24-hour urine calcium, which is important. And usually these suffice to be checked once a year. That's how I check them. Now this I wanted to point out. This table can be, this you can Google and you can find. But this is very important because a lot of people don't think about this, and a lot of physicians don't think about this. So when there's an increased risk of cataract, you should have at least one baseline. We call it a slit lamp or an eye exam, which should be considered if you've had this disease for a long time, right? In chronic hypoparathyroidism. And thus baseline, an ultrasound to check if you have a kidney stone or not is not a bad idea. You don't have to keep getting it every year, but maybe once in a couple years, some kind of renal or kidney imaging should be done. And then brain imaging for those calcifications. Now, we don't know how much it'll help, but it's good to know your disease. It's good to kind of have a hold of the enemy. You should know everything about it. So sometimes just having like a baseline, some kind of brain imaging also helps. All right. But to finish up, I just wanted to say that this disease is complicated, huge financial, emotional burden, quality of life reduction. And so you really need a multidisciplinary team helping you out. The endocrinologist is great. Sometimes acutely in short term, the surgeon really helps you out. And then if the patients are visiting the ER, your ER physician will be helping you out. And of course, your family doctor or PCP. But don't forget about the kidney doctors who help monitor the 24-hour urine, or the psychologist helping with that anxiety, right? And dietitians who can give you suggestions on calcium and phosphorus and how to manage that. So it's really like a village kind of helping patients kind of deal better with this disease. But with that, I'll finish up. It's a quick summary.
I have two questions. Number one, can the calcitrol or the calcium supplements cause a lot of plaque in the heart and carotid arteries? That's question number one. Question number two um, is one of the symptoms that we can get a feeling of vibration in our bodies all the time? Like, I've got this vibrating thing going on. Those are my two questions.
So absolutely, yes. Like I said, the patients feel those symptoms in different forms. I've had several patients tell me about that vibration, and they can't really describe it. So you described it well. It's like a vibration. So yes, totally can be due to the low calcium. Now the calcium and the calcitriol, if you over-replace, if you keep that calcium on that high normal range, then yes, that extra calcium can start to build up in the heart. So that's why you want to target a low normal range, which is 8 to 8.5 milligrams per deciliter, something just right enough to kind of eradicate your symptoms. But it's complicated because when you feel that tingling and that vibration come on, you're tempted to take those extra Tums. So it's a hard balance to achieve, but yes, if it's too much, it can cause problems.
I'll just add as far as how magnesium works. So when both calcium and magnesium are in their salt form, and we have to go back, remember our chemistry from high school, they're both 2+ cations. And so they can kind of sometimes interchange as far as how they help with how our nerves work and how our muscles contract. And so if your magnesium is also low, you're going to have those symptoms a little bit more exacerbated because they're kind of having to cross cover each other. And if they're both low, they're not able to help the muscles relax or help the nerves relax. And so there's a little bit of, like I said, with how a lot of phosphate and calcium and magnesium all interact, it boils down to some more basic chemistry that we all probably forget from high school because we don't deal with it anymore. But what you're feeling in your body is how that positive charge, they kind of interplay and step in for one another.
I'm going to read one of the questions from the chat. Can parathyroids wake up, improve 18 years after surgery? I am hypopara. I have some PTH, but always low. Blood tests over the last 12 months have shown PTH at the bottom of the normal range while calcium is normal. So it looks like they could be waking up, but I have not heard of this.
So whenever we talk about both the short term and the long term, you can have PTH measurable in your body, but it may not be enough for what your body needs it to accomplish. And so that's why it's not, your doctors shouldn't just be saying, oh, well, your PTH is now measurable, we can stop all of your calcium. It may not be at a level that's high enough for you. Over years, and depending on what lab you go to, how we test for PTH can change, and the reference ranges may change as well. And so realizing, I know my hospital institution just changed their reference range a couple of years ago, where now our upper limit of normal is 100 where it used to be 65, and it brought up the lower limit of normal. So everything kind of scales. Whenever that happens, you can't compare that absolute number to the old test. It's really how much help are you needing to require or to maintain that particular calcium level.
I didn't see the gummies up there. What do you guys think of the gummies? I've had great success in managing labs and symptoms with the gummies.
The gummies is absolutely in favor of whatever works best, because it's something that you're going to be taking long term. Just paying attention to that elemental calcium, like how much and how many pills that's leading to, and being careful of taking it with food or not, like some of the caveats Dr. Oltmann had mentioned.
I think I've had you also have to pay attention to what's linked to the calcium in the gummy formulation. I think some of the early ones were actually calcium phosphate, which is you already have too much phosphate. And so just making sure, depending on what form of calcium they're putting in the gummies, it potentially could cause more harm or good. I think the number of different gummy formulations out there have changed dramatically in the last several years, so that's a good thing. The other thing with gummy formulations just across the board, whether it's calcium or other vitamins, how they put it in this little gel, a lot of it you kind of poop out whole. That unless you're chewing it down to it's almost slime in your mouth and swallowing it, so much of what's in the pill stays trapped in the gel and doesn't actually make it into your system. And we see that a lot when people have transitioned over to the gummy multivitamins and whatnot, thinking that that's a way to gain people's compliance. They end up just chewing it twice and swallowing it, and it just doesn't quite break down to where they can absorb it as well.
Yeah, so that back of the bottle, I think that's very important to maybe even run it by your doctor to say, are the constituents or ingredients looking okay? Yeah.
Hi, for the chronic kidney disease it is developed during this, how is that treated? And can it be reversed with good treatment of the hypopara?
So it is usually the progression can be halted by treating it in the right way, but I don't think it's reversible. That's number one. It's treated just like you would treat any other chronic kidney disease. So you have to be careful about what kind of calcium, phosphorus, the levels have to be maintained. That product has to be maintained less than 55. So the calcium phosphorus product is very important. We usually will, your doctor will set you up with a renal or a nephrologist who will follow you along. And then same things, looking for imaging, making sure no stones, if there's any calcifications. So the approach is similar to another chronic kidney disease, I would think, just with a couple other caveats that you have to pay attention to.
I'll just add, chronic kidney disease is very multifactorial. And so while this may be a new risk factor for you that most other patients with chronic kidney disease do not have, it's also making sure other risk factors for chronic kidney disease like high blood pressure, diabetes, your diet and the salt in your diet, those are also other things that can contribute to chronic kidney disease. Usually, with hypopara, it just becomes additive to the other factors that are going on in everyone else. So it's also making sure that those other medical problems are in the best place that they could be.
And did you say that calcium should be taken separate from multivitamins?
Yes, that's what I suggest to my patients. And it's hard to kind of time them, especially if you're on, post-surgery, you're on thyroid medication as well. So that it is challenging. But usually clubbing it up with something that has iron in it is going to interfere in its absorption. Yeah.
The other thing too is your body can only absorb so much calcium at one setting. And so you may be, if you're taking a multivitamin, if the multivitamin doesn't have iron in it, would that be okay?
Yeah, I think what you're trying to say is multivitamins already have some calcium, and then you're adding extra calcium on top. And like she's saying, there's as much as the body can absorb at a time. That's why, spreading it out is a good idea.
Someone in the chat is asking, I've been told taking Tums long-term is harmful. Is there any truth to that? Should I change to other options?
So, like Dr. Oltmann was saying, the Tums can have the phosphorus in them too. And remember, they're used for like acid reflux, etc. So the constituents in that are long term. You have to be just careful. Again, the back of the bottle is so important. Like, what all do they have? So you have to be just careful with that.
Is asking, I had severe low PTH after surgery, but it improved and I am only taking calcium and vitamin D now. Do I need, or is it suggested to be on calcitrol? Is there ongoing PTH test that I should be getting?
So just checking the plain old, like parathyroid hormone level, will be a good idea to see what's going on. Now, certain supplements like biotin, etc., you just have to be careful. Some medications can interfere in those assays on how it's checked. But keeping all that in mind, you can just check a parathyroid hormone level in the blood, and it'll guide you to how it's functioning.
And in the short term, what determines is that hormone level going to be enough for you is what happens if you stop your calcium supplement and your vitamin D. So if the calcium tanks, then that's letting you know that whatever amount of PTH hormone you're making is just not enough for your body, and that you need to have some supplementation. I think patients may be different as to how much help they need, and that's where it's not just the calcium level, it's the hormone level. It should be something that's being done in partnership with your doctors.
Someone else is talking about, I have heavy calcifications and ossifications everywhere. I'm a Met patient, and even my latest pathology from my neck dissection was papillary with heterotopic ossification. Then they go on to ask, what is the best way to handle these ossifications once they've already happened?
So I would think it's a complicated question because depending on where that calcification is and what impact. Remember, we said sometimes in the brain, it's very worrisome if you have calcium depositions in the brain, but might not cause any clear-cut symptoms as such. And in the kidney, then it can lead to some like kidney insufficiency. So it'll need kind of your, I don't know, it's a complicated question to answer just like that.
Some cancers can have ossification as a part of the tumor that's completely independent of parathyroid and calcium balance. It's more a function of the tumor pathology. And so just knowing that you had ossification in your tumor that may or may not be related to the hypoparathyroidism. More of our knowledge about heterotrophic ossification comes from our dialysis patient experience because they have dysregulation for other reasons. That's where the calcium and the phosphate. So going back to the chemistry lesson from high school, calcium's positive and phosphate is negative, and plus and minus love each other, and they want to bind together. So if you have too much of that around in excess, they stick together and clump together. And so it can happen in the blood vessels. In our dialysis patients, they can actually have it start happening in the skin or in the soft tissues where it causes sores. But that's where the phosphate piece comes in, is where is the extra calcium still floating around in solution, or is it finding something to stick to and then it falls like a rock and sticks to whatever's around it? I think we might be out of time.
Yeah. There's two quick ones. One is just, will vitamin K2 help prevent calcium from building up in arteries and help it absorb in bones?
So there's some mixed literature about that. Usually the calcium supplements will come combined with like vitamin D and the K. Best to run it by your doctor to be sure, but for most part, I think it's not a bad idea to have that on board, unless you have some related, like some other comorbidity that inhibits, because, vitamin K is like, it's important for other things. And what's the other question?
How much does the Yorvipath cost? I don't know if you can answer that.
Yeah, no, I don't know. I know it's very, very expensive. Yes, extremely expensive. I don't have an exact number.
Okay.
But there are a lot of patient assistant programs that they have that, we can reach out to.
Great. Thank you both for being here. Thank you, everyone.
Insurance?